Every year, invasive fungal infections affect more than 2.1 million people worldwide. For those in high-risk categories, the crude mortality rate exceeds 85%, leading the World Health Organization to classify Aspergillus fumigatus as a critical priority pathogen. These infections manifest during periods of profound systemic vulnerability. This is seen most acutely during viral surges, where standard pulmonary defenses are compromised, and environmental fungi can establish a foothold in the lower respiratory tract. To analyze the mechanisms behind this lethality, we synthesized a comprehensive review of clinical literature and taxonomic data. You can access the specific research materials used for this report in the linked Notebook LM document in the description. The data shows that Aspergillus fumigatus is a highly specialized biological threat. It thrives by exploiting modern medical interventions, including intensive chemotherapy and prolonged stays in the ICU, to target vulnerable patient populations. For over a century, mycology used a dual nomenclature system. The asexual stage of the fungus was named Aspergillus, while the sexual reproductive stage was assigned to an entirely different genus, known as Neosartoria. In 2013, the International Botanical Congress replaced this system with the one fungus, one name rule. Distinct taxonomic branches were consolidated into a single unified node, reflecting the genetic reality of the organism. This genomic unification followed the discovery that Aspergillus fumigatus possesses a functional sexual cycle, producing mature fruiting bodies when compatible mating types are crossed. This capacity for sexual recombination allows for rapid genetic diversification. It provides a biological mechanism for the fungus to adapt to environmental stressors and develop new resistant traits. The shift in nomenclature acknowledges this underlying evolutionary mechanism. Standardizing the name reflects the discovery of a species that uses sexual reproduction to facilitate global drug resistance. Unlike endogenous yeasts like Candida, which are part of the human microbiome, Aspergillus fumigatus is an environmental intruder. It is specialized for the transition from soil and organic debris to the human respiratory tree. Aspergillus demonstrates superior thermotolerance, surviving temperatures up to 70 degrees Celsius, making the human body's 37-degree environment optimal. Its dimensions are equally critical. At just 2 to 3 microns, the conidia bypass upper airway filters, depositing directly into the terminal alveoli. Once in the lungs, the fungus uses a chemical cloak to hide. A hydrophobic layer of Rod A and Rod B proteins, combined with DHN melanin, masks its immunogenic cell wall components. This prevents host immune cells from detecting the spores before they can germinate. These biological advantages, extreme heat tolerance, microscopic size, and immune evasion, allow Aspergillus fumigatus to infiltrate human physiology undetected. In the warm, moist environment of the alveolus, the dormant spore begins isotropic swelling. It reactivates its metabolism, preparing to switch from environmental survival to tissue colonization. The spore initiates polarized growth, extending a germ tube that matures into a branching hyphal filament. This transition marks the beginning of active tissue damage. These growing hyphae secrete hydrolytic enzymes, such as proteases and lipases. These chemicals degrade the structural proteins of the respiratory epithelium, allowing the fungus to penetrate the basement membrane. This penetration leads to angioinvasive, the hallmark of severe aspergillosis. The hyphae grow into the pulmonary blood vessels, directly interacting with the circulatory system. Angioinvasive causes intravascular thrombosis and localized tissue death. These infarctions create a hypoxic environment where oxygen levels are extremely low, creating a niche that the fungus is specifically adapted to inhabit. This morphological shift from spore to angioinvasive hyphae is the mechanism that converts a localized exposure into systemic failure. The clinical manifestation of the disease is determined by the specific immunological barriers that have been compromised in the host. In patients with structural lung damage from prior tuberculosis or COPD, the fungus can cause chronic pulmonary aspergillosis, leading to the slow destruction of lung tissue over several years. For those with asthma or cystic fibrosis, the fungus may trigger allergic bronchopulmonary aspergillosis. This causes severe inflammation and the production of thick mucus plugs that obstruct the airways. Profoundly immunocompromised patients, such as those with neutropenia or stem cell transplant recipients, are at risk for invasive pulmonary aspergillosis. Without enough neutrophils to attack germinating hyphae, the infection can spread rapidly, leading to refractory fever and hemoptysis. We are also seeing a rise in secondary invasive infections during severe viral outbreaks. Conditions like kappa and IPAPA emerge when COVID-19 or influenza damage the respiratory lining, allowing the fungus to cross the epithelial barrier. Aspergillus is a dynamic opportunistic pathogen, capable of altering its attack strategy based on the specific immunological deficit of the host. Standard microscopy and culture methods often take days to produce results. In high mortality cases involving cryptic species, this delay can be a significant barrier to effective treatment. MALDI-TOF mass spectrometry addresses this by analyzing the unique protein signature of the fungus. It compares a peptide mass fingerprint against a database of known spectra to identify the species in minutes. Clinicians also utilize fluid biomarkers like galactomannan assays to detect fungal cell wall components or Aspergillus IgG precipitans to confirm a chronic infection. To determine which drugs are effective, laboratories perform antifungal susceptibility testing. Standardized UCAST microdilution methods measure the minimum concentration required to inhibit growth. Genomic surveillance is now used to identify triazole resistance at the molecular level. Pathologists target specific mutations in the CYP51A gene that physically prevent antifungal drugs from binding to their target enzyme. While patient recovery involves multiple clinical factors, the laboratory's ability to decode the fungus's genomic armor provides the specific data required for effective medical intervention. Standard treatment protocols typically rely on voriconazole or liposomal amphotericin B. However, the choice of therapy is increasingly influenced by local resistance patterns. Models like the Dutch SWAB guidelines prioritize early empirical therapy based on local data, emphasizing strict antimicrobial stewardship to ensure that available drugs remain effective. New therapeutic classes are entering the clinic to address resistance. Fosmanogepix works by blocking the GWT1 enzyme, disrupting the way the fungus anchors proteins to its cell wall. Another novel drug, olorofim, targets a completely different pathway. By inhibiting dihydroorotate dehydrogenase, it blocks the synthesis of pyrimidines, preventing the fungus from replicating. Managing the risk of infection also requires environmental control. Hospitals use molecular fingerprinting to trace clinical isolates back to potential reservoirs in water distribution or air filtration systems. Addressing the threat of Aspergillus fumigatus involves the combination of molecular identification, targeted novel therapeutics, and rigorous environmental surveillance. Subscribe to Insight Engine for more clinical deep dives.